Our series for Accords this year is focused on social determinants of health, and that part 2 will kick off in just a few weeks with a talk from Megan Morris, who's our qualitative and mixed methods core lead in Accords, with an overview of social determinants of health and how we address it in clinical and community settings. We have a number of speakers lined up for that series as well, focused on screening and documentation of child adverse events, screening for social determinants of health, a really great panel on that, social network analysis, a focus on pediatric settings, and a variety of other things. So put that on your calendar for March, and we'll have more notices coming out as well. Something else to bring your attention to, there's a few flyers around. There we go. A call for abstracts for the Colorado Pragmatic Research and Health Conference that we'll be putting on in June, June 10th and 11th, where there's a call for poster abstracts. You can see there's flyers on various tables around here. We invite you to apply or to submit an abstract for that. And then there's an RSVP on our website and for Accords, as well as at coppercon.com to get on the list for registration. So if you have any questions about CopperCon, let me know. That will be focused really broadly on different aspects of pragmatic research, pragmatic trials. So with that, I'm going to introduce our speaker. So please join me in welcoming Dr. Maria Fernandez. She's a professor at the University of Texas Department of Health Promotion and Behavioral Sciences, and she's a member of the School of Public Health faculty and has been there since 1998. She's the director of the Center for Health Promotion and Prevention Research, or CHPPR, at the UT Health School of Public Health. So she leads the group that is our Accords Parallel at the School of Public Health there at UT Health. She's an expert in multi-level intervention development and implementation science. Her research interests include health disparities, cancer control, health promotion planning and evaluation, health informatics, health communication, and dissemination implementation science. Her work is featured in over 140 peer-reviewed publications, including journals such as the American Journal of Public Health and Preventive Medicine. We're so excited to have her visiting us here today to discuss planning and implementing intervention strategies for increasing health equity. Help me welcome her to our campus.
Hello, everyone. Thanks for coming. Can you hear me okay? Okay, not too loud? Okay, all right. So thank you to the Accords group for the invitation. It's a real pleasure to be here. So as you know, I'm from Houston, so I think I was like overly concerned about the weather and wore like a lot of layers and things, so I may have to take my jacket off at some point. I'm going to be talking about a topic that is, I think, really important to me because, as you'll see, and I'll talk a little bit about, multi-level interventions, I think, are really the only way to address health inequities. And over the course of my career, I've done a lot of work around the further development of frameworks for doing that. It's really challenging, and I'm going to be talking to you about a number of different topics and probably going much faster than you'd like over some of them. But the idea is to give you some exposure to some of these concepts and processes so that if you have more interest, there's certainly other opportunities to do a deeper dive. I'm just going to give a little bit of an overview on health equity, and in particular, how we think about social determinants of health influencing health equity. But given that this is a health equity seminar series, I'm not going to go too much into that because I'm sure you've heard some excellent talks on that topic. I'm going to spend more time talking about multi-level intervention planning, and in particular using intervention mapping, which is a planning approach that I'll describe in some detail. I know that several of you have heard about intervention mapping before, but really aren't familiar with what are the steps and what does it entail. And so I want to demystify it a bit here, and there's always a risk in doing that because you may walk away thinking, wow, I'm never going to ever do that. That's way too complicated. But you also may walk away thinking, even if I never apply it, I think that there's some important concepts, and the logic of it is something that could certainly be helpful. That's my hope. I'm also going to talk about implementation mapping, which is the application of intervention mapping for planning implementation strategies. And throughout, I'm going to give you a few examples of different projects, and at the end, a little bit more detail about one in particular. I'm going to try to wrap up with enough time for some discussion, questions and discussion. But feel free, if you have a question during the talk, please let me know. So what are social determinants of health? They're conditions in the environment where people are born, work, live, and play that affect their health outcomes and also their quality of life. And they're things, we think about things like transportation, housing, neighborhood, work environment, income. These are all, if you look at them, they're all things in the environment. And so thinking about health equity, thinking about addressing some of the social determinants of health, really multi-level approaches are the only way to do it. If we focus just on individuals or just on providers, we're really not going to be able to make a dent at all in this area. So when we think about health inequities, they're inequalities that typically are characterized by unfairness or injustice. So that's the way that people distinguish between the term inequalities versus inequities. And Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And the former director of NCI said, poverty is a carcinogen. And then probably best said by you too, where you live should not decide whether you live or whether you die. So there's a number of different mechanisms that underlie the relationships between social determinants of health and health outcomes and contribute to health inequities. And these include things like negative experiences in environments, things like discrimination, chronic stressors, violence, interpersonal and intrapersonal resources, so the social support, the people around you, the social capital of a community. And then certainly things that are internal, motivation, agency, and behaviors. These all contribute to inequities. This is a figure that Steve Taplin included in a really nice supplement to the Journal of National Cancer Institute on multi-level interventions across the cancer care continuum. And I know you probably can't read some of what's in these boxes, but it's really various examples of what do we mean when we talk about these different levels. When we talk about the individual, the socio-demographic, the knowledge, attitudes, beliefs, biological factors, the team, the provider team, knowledge, communication skills, their cultural competency and other things, and then all the way up to things like national health policy, and in cancer, there are things like Medicare reimbursement and national cancer initiatives. This is from some work that we did some years back, really when the HPV vaccine was people were becoming more aware of the vaccine, and we were trying to understand what factors influence acceptance or uptake of vaccination. And so you could see here that we looked at various behavioral science. This, by the way, was a review in annual reviews of public health. So it was a review of the existing literature at that time. And we were able to characterize various interpersonal, organizational, community factors that influence the behavior, influence vaccination among parents making decisions for their kids, but also among people in the catch-up age group. And then just recently, and I wanted to highlight this because this just came out about, I think, a week ago. This is one of my graduate students, Serena Rodriguez, just published sort of an update of this. But in fact, this was a review of reviews looking at factors that influence HPV vaccination. And we see a lot of the similar things. So even 10 years later, but now with actually more conclusive evidence of the number of different factors across levels that influence HPV vaccination. So I wanted to say something about complexity because I recently participated in a conference at the National Academies of Science, Engineering, and Medicine in Washington, and it was sort of the launch of this guide called Guiding Cancer Control: A Path to Transformation. And it was really focused on this idea of cancer control in a complex adaptive system. And the idea of a complex adaptive system is that there's diverse components and actors that interact with each other and with the external environment, that this complexity is a property of both the context, but also the interventions, and that there's an unpredictability of effects, right? So very compelling, seems right? Everything affects everything. When I first started looking at of this idea, my reaction was a little bit like this. Like, what am I looking at, and how am I supposed to do anything with this from an intervention perspective, right? But I think that one of the things that we have to keep in mind is that when we think about systems approaches, and systems thinking, it invites new approaches to addressing the issue. I'm not going to talk about these approaches. I am going to, at the end, sort of tell you a little bit about some of the things that's being done, but I am going to talk about how we can develop interventions that address some of these factors that we know influence and have reciprocal relationships and things. But I think that there's a lot of work, and this is in this area, to actually do an even better job of it than some of the things that I'm going to talk about. The question, right, when you look at something like that, oh, and by the way, I didn't mention, this is, in case you can't see it, this is sort of the obesity, right, the problem of obesity. And all of this, you might initially think, well, it's a pretty straightforward issue, but really this is a representation of all of the interacting factors that influence the obesity epidemic. So how do you intervene and improve implementation of evidence-based interventions in a complex adaptive system? Well, again, you don't want to do this. You don't want to say, well, this is too complex, I can't handle this. But we need approaches to try to address some of these multiple levels. And there are several approaches. There are several frameworks, particularly in health promotion, for developing multi-level interventions. And these are some of them. But today I'm going to talk about intervention mapping. So what is intervention mapping? It's a systematic approach to program development, implementation, evaluation, and also adaptation. And it provides a framework for decision-making at each step of the planning process. It helps incorporate things that we know matter, right? Theory. We know that theory matters, but we're not always sure how to incorporate it into our planning process. The same with empirical evidence. A lot of times you have conflicting evidence, insufficient evidence to make decisions in the planning process. And then also community input. So these are all things that many of you may have had training in and have used in your planning efforts. What we find in the real world, right, in health departments and even with people with masters in public health and other types of practitioners that have some exposure to these things these tools that we know are important, they often don't know how to put it all together, how to put it together in the planning and daily decision making in the development. Another feature of intervention mapping is that it uses this ecological approach to planning. So what do I mean by an ecological approach? Well, it helps address not only changing behavior of individuals, but also addressing the behavior of those people or organizations or systems in the environment that influence both behavior or influence health directly. And so it helps us address the complexity of multi-causation of problems and multi-level intervention points. I've said often that when we think about having an impact and increasing implementation and dissemination of evidence-based programs, that intervention mapping can help in 3 distinct ways. And one is designing multi-level interventions in ways that from the beginning enhance their potential of being adopted, implemented, and maintained. And that's kind of what I'm going to be talking about mostly today. And then the other is designing implementation strategies, which I'm also going to mention today. And then the third, which I won't talk about, but is an area that I'm keenly interested in, is using intervention mapping processes for adapting evidence-based interventions. So these are the steps of intervention mapping. And I won't list them now because we're going to go through each one of them. And I'm going to just give you a little bit of a description about the step. I'm going to be going over them fairly quickly because, like I said, I want to give you some exposure to what these steps mean and a few examples, but really to kind of walk away and be able to apply it. Really, you either have to have the book, maybe do a training. We offer week-long trainings. It didn't work out on this trip, but I am going to be coming back and doing, I think, a half-day training at some point soon. But certainly, if you have questions as I'm going through, please either stop me or ask me at the end. Okay, so one of the things that I wanted to mention before I start, and I know that this is something that for many of you is a given, and you know this, but it's something that intervention mapping holds really central in the planning process, and that is participation. So participatory planning, using community-based participatory planning and research sort of principles, with the acknowledgement that knowledge generation comes from the hands of practitioners and also implementers. And so the equitable participation in planning efforts is a central element of intervention mapping. And even though because I'm going to be doing this quickly, I'm not going to highlight that through every step. At every step, there's guidance on how and why you would be including the community in this step. So, so as we know, equitable community or clinic participation ensures that programs focus reflects the community. It brings greater breadth of skills to the planning team, and it improves external validity because you're a lot lower risk of developing something that nobody would use if the people that are going to use it are at the table when you're planning it in the first place, right? So step 1, needs assessment. So the idea of step 1 is to develop this logic model of the problem. And the logic model, you'll see in a figure from now in a minute, includes what we know about the behavior and the factors that influence the behavior, but also what we know about the environment at multiple levels and the factors that influence the environment. And these are just different tasks, and I'm not going to read them all, but you'll see that the first one is establish a planning group. And the planning group, it's critical to have stakeholders, as I mentioned. And then at the end of this step, you will have goals. You'll have program goals. So here's a logic model of the problem, and this one articulates the questions that you're asking in each of these boxes. It is modified from the pre-seed framework. Raise your hand if you've ever heard of pre-seed. Pre-seed, proceed, yay, okay. So you'll be happy to know that there is a new edition of the pre-seed, proceed book, long overdue, coming out, I think, by the end of the year. So if you know pre-seed, then you'll recognize this. And one of the modifications that we've made in intervention mapping is that we don't specify predisposing, reinforcing, enabling factors, and there's lots of reasons why. And if anybody wants to talk to me about that afterwards, feel free. Because I just wrote that chapter in the new pre-seed book, so I'm very cognizant of like some of the differences and the pros and cons of thinking about it that way. But anyway, so here, looking at this framework, you can see that we're asking questions, and I'm going to focus on here because the behavior ones you've probably thought about before, but for the environment, what interpersonal, organizational, community, and societal factors influence either the behavior or the health problem directly? So there's some things that can make people who are at risk directly sick, right? And then there's some things in the environment that will influence their behaviors. Here's an example from a project that it's ongoing. The study is ongoing, Salud por la Vida. It's in Puerto Rico, and it's focused on increasing colorectal cancer screening. An example of the needs assessment, these are some of the sources that we looked at to try to understand the problem. We also conducted surveys and focus groups. We did mixed methods approaches to understanding the problem and try and really kind of fill out each of these boxes. And the boxes, keep in mind, it's just a representation of all of the information that's really contained in each one. And it's to help us sort of understand this causal framework. When we're working on a logic model of a problem, we start over here. We start with the health problem. And sometimes if we're lucky and we have resources that aren't attached to a health problem, we actually start with the quality of life concerns of a community or a clinical setting, and then go right to left. But that's how you work, but causally, you think about it this way. So what's to the left causes what's to the right. Okay, so the second step is to articulate program outcomes and objectives. And here we're actually sort of doing a flip of the logic model of the problem in that we're articulating a logic model of change. Okay, so if that's the problem, what needs to be different? What needs to be different in the behavior, in the environment, in the determinants of those? And an important part of this is number 2, which is specifying performance objectives. And performance objectives are answers to the question of what does the person have to do in order to do this behavior, or if it's an environmental factor, what does someone in the environment have to do to change that environmental condition? And then task 3 is understanding the determinants of both the behaviors and the environmental conditions. And for those of you who do a lot of work in implementation science, those determinants are often those contextual factors that may be influencing a particular condition. And then we construct these matrices of change objectives. And this is where you're going to start getting worried, because it looks like a lot of work. And in fact, it is. But it's really helpful. Do you have to do matrices of change objectives to do intervention mapping? No, you don't. But it is really helpful. And essentially, you're creating this logic model of change. So I'm gonna just show you some examples. But first, what do we mean by behavioral outcomes? So in this case, this was a project, Active Play. And it was a project that a colleague of ours, Andrew Springer from our Austin campus, was the PI on. And so the goal was for students to participate in 30 minutes of physical activity during school. So that's the behavioral outcome, pretty straightforward. And then the environmental conditions included things like, when they looked at the problems, there was really no where to play, there was no time, there was no led activities that guided students to play during recess hours. And so these are some of the environmental conditions that were articulated to help improve that issue. So I kind of skipped the performance objectives for now, but again, the performance objectives ask the question, who has to do what in order to bring this about? But the matrices of change objectives are essentially, you put the performance objectives on the side, the determinants up on the top, and the determinants are things like knowledge, attitudes, self-efficacy, perceived norms. These are things that we know from theory influences behavior. And we ask, well, what has to change? Can you guys see this if I use my mouse? No, you can't. What has to change in this determinant in order to achieve this performance, right? And so it's a very sort of detailed, systematic process. And these are the kinds of things that you might see in a matrix. Now, this is just a portion of a matrix, and this one is a behavioral one, and the behavior is consistently and correctly using condoms during sexual intercourse. I chose this example because it always gets people's attention anytime you're talking about sex or drugs, or and so here you're on the left, you can see there's some really specific behaviors, right? It doesn't just leave it at use condoms. It's like, what does a person have to do in order to use condoms? Well, they have to buy them, carry them with them, negotiate with their partner. So it goes on. This is just and then what are the factors that may influence them? What are those determinants? And then when we create these change objectives, we're crossing the determinants with the performance objectives and coming up with very, very specific, what we call change objectives. Now, how do the change objectives help us? Well, you can imagine when it gets to the point of developing actual materials and content for the materials, you know what has to be there. And this is a really quite different from what people usually do in the development of interventions, right? Usually you'll see content in materials that it's largely knowledge-based, right? But it's not getting to the attitudes or self-efficacy or other factors that actually really have a major impact on behavior. The next, and this is sort of the logic model of change, which kind of extends what we saw before, and including those other elements that we just talked about. So step 3, just checking my time here, step 3 is program design. And the key thing here to pay attention to is the selection of methods and strategies, or practical applications. Methods and then practical applications of those methods. So what do we mean by that? Well, a method is a general approach. Think of it as the mechanism of how something is going to happen, that we know from theory and from evidence influences the determinants that we've identified, right? So there are particular methods that influence certain determinants. So for example, modeling is a method, comes from social cognitive theory, and it influences self-efficacy. And it can also influence skills. And so we think about those methods, we choose methods, and then we operationalize them, and operationalizing them, developing these, what we used to call strategies, and now we call practical applications of methods. We do that in a way that's consistent with the context and consistent with the population and the delivery system. So here's just an example of that program called Actívate Ya, which is a physical activity promotion, tobacco prevention in Uruguayan youth. And here, this is a table that represents sort of the product of some of these steps that we've just been seeing. So you'd have determinants and change objectives over here, the methods, and it also happens to include the theory behind that method, and then the application. How is it operationalized? Back to the colorectal cancer screening example, in this step, we were choosing theory and evidence-based change methods at a couple different levels. So the first two were to function at the individual level, and they included entertainment, education, and behavioral journalism. And these are some definitions if you're not familiar with those. And then in the clinic level, we used patient activation or patient-mediated intervention to influence provider behavior, right? And but within those overarching methods, right? So if you think about entertainment, education, behavioral journalism as overarching methods, there's a lot of other things that are happening there. So program production, now you have the methods and practical applications, now you're actually producing the material. So there's a lot of guidance in here about how to work with creatives, how to develop design documents, that sort of thing. And here's just some example from the Salud por la Vida program. We developed a tailored interactive multimedia intervention delivered on an iPad or tablet, which included vignettes and stories, and then also some questions. It was very tailored to the individual's current knowledge and interests and their own barriers, etc. The development of that tailored approach was driven by the methods and strategies that we developed, and also the content through the process. We also had print materials, provider prompts, and then reminder support calls. So as you can see, it was both individual, provider, and clinic interventions that were developed. And in the previous process, we remember we talked about the matrices of change objectives. There's actually different matrices for every level, right? So, all right, I'll keep going. So I'm not going to talk too much about step 5, because step 5 is analogous to implementation mapping, which I'm going to talk about in just a minute. But essentially, it's once you have an intervention, how do you adopt it? How do you increase adoption, implementation, and maintenance? And you might be looking at these steps, and if you're paying attention, you'll think, well, wow, this is kind of like what we've just been talking about in steps 1 through 4. And I'd say you're right. In step 5, it's sort of like a mini intervention mapping, but the target is different. Now we're not talking about the individuals in the at-risk group, or even the environmental actors that are making changes in the environment to facilitate behaviors or to improve health. Now we're talking about the people that are responsible for making the decisions to adopt the intervention, to implement it, and to maintain it over time. And so that's what step 5 is. And I'll talk in a minute about how step 5 has sort of become implementation mapping. And then finally, evaluation. And I won't say much about this except the fact that once you've gone through this process, evaluation is actually pretty easy, because you've really articulated what you expect to change. The matrices of change objectives actually help you develop measures for some of those determinants where measures may not have existed, and measures that are specific to evaluating your intervention. So this is the large sort of logic model, intervention logic model, where you can see how what's on the left, the logic of how it's supposed to influence all the way through behavior and quality of life. Okay, I'm now going to switch to talking about implementation strategies. But first, a little bit of background on implementation strategies. So now raise your hand if you are a dissemination implementation researcher or wannabe researcher. Raise your hand. Okay. Good. Okay, so about half. All right. So I feel like we're all wannabe implementation science researchers, right? Because the field is so young. A lot of times I feel like we're stumbling around in the dark. So what are implementation strategies? So implementation strategies are methods or techniques used to enhance the adoption, implementation, sustainment, and or scale up of a program or practice or innovation or policy. So I'll say intervention, usually. Sometimes I use other terms, but what I'm talking about is any of those innovations, right? So what do we know about strategies? Well, Byron Powell and Nola Proctor and others have done just a phenomenal job at looking at the literature, primarily the health care literature, but nevertheless, looking at the literature and saying, what have people done to increase implementation? And what's on the right here is sort of the second round of this expert recommendations for implementing change, the ERIC strategies. And what they did is they grouped them in buckets, right? They said these are sort of the buckets of implementation strategies that are out there. And within each of those buckets, there's a lot more detail of what kinds of implementation strategies are there. Now, this is very important work because before this, it was sort of a mess. Like nobody had tried to categorize them or label them. However, what a lot of people don't realize is that this was not tied to outcomes. Like this is just what people are doing. We don't know if they work or not. And in fact, there's little evidence about not that they don't work, but there's just not that much research that looks at do these things work. And then when there is, like for example, audit and feedback or assessment and feedback, there actually is quite a lot of evidence of research that's been done in that strategy, but the effect size is really small. It's between like 2 and 9%. So anyway, there's a lot of work to be done in strategies, but most people think of it this way. They think, well, it's a two-step process. I'm going to conduct an assessment of the factors that influence implementation processes and outcomes, and I happen to have some really nice measures to understand context, and so I'm going to really understand context, and then I'm going to choose strategies to influence those. Well, that sounds great, but bad news, it's not that easy. And I love this quote, which somebody told me was actually a misquote, but I'm just going for it. It's a quote. Everything should be made as simple as possible, but not simpler, right? So this I think is a really important message, because I think naturally we want things to be simple. Naturally, we want to plug something in. I'm going to plug in my barrier, and out is going to pop a strategy for me to address it, right? That's too simple. That's too simple. We need to make it simpler. And I would say simpler than what implementation mapping is currently available. And we're working on that. But we can't make it too simple, because then we're just going to miss the boat. And there's a lot of, but to be fair, there are a lot of challenges in selecting implementation and dissemination strategies. And it includes things like, while some compilations exist, like ERIC, they may be less relevant for certain settings, like the clinical versus the public health setting, depending on what literature they were looking at to compile those lists. Strategies included in these compilations are broad and may represent qualitatively different things. If you look at that list of ERIC strategies, some of them are delivery channels, some of them are assessment processes. One of them is like, get more funding, right? Like, okay. You know, and so, you know, what does that mean? Like, these are really different things. There's an underutilization of conceptual models and theories in the literature, and that makes it hard to figure out what to pick and what to use. And there's variations related to the evidence-based programs or interventions that you're using and the context in which they're implemented. And these are all like reasons why it's hard. So I'm going to tell you about this study real quick that was done. Oh, by the way, this is in the discussion of this study that I'm going to tell you about. And I'm pointing that out because, well, wait a minute, I don't want to ruin it. I'll tell you in a minute. Okay, so there's this cool study. I got involved later, after it was already done, that Laura Damschroeder and Tom Waltz and others did, where they wanted to match strategies to CIFAR barriers, right? So what they did, it was actually really cool. They recruited experts, 169 experts. That's supposed to be an equal sign, not a minus sign. And experts meaning that they knew about CIFAR. They knew about implementation. And they did this thing where there would be randomly pop up a barrier, a CIFAR related barrier. And then they had to choose one of the ERIC strategies. So what they had to do was they dragged one of the ERIC strategies onto this barrier, right? And there were lots of iterations, like they had to do it over and over again. So the goal was, let's find some strategies that are good for these barriers. So what happened? Well, there was an average of 47 ERIC strategies for each CIFAR construct. So out of the 2,847 possibilities of matching, the bad news is that at least one respondent endorsed 64% of those, right? So the good news is that there's possible, you know, combinations that were reduced by 36%. So bottom line, there was an agreement. People did not agree about what strategy should be used for what barrier. So, And the reason I mentioned the Waltz paper is because even though that paper sort of resulted in not much agreement, I think we do a good job of talking about why, and the why, and you can learn a lot from the discussion, I think. So it's complicated to develop strategies, but people say, but I have this list, and Byron always says that I'm making fun of him with this picture, but that's not supposed to be Byron. He doesn't wear glasses, so it's clearly not him. It's just some anonymous implementation science researcher who's a little confused. And so even if you have a list, right, and even if there's more evidence that says, oh, well, actually these strategies are good for this, you still have to develop the guts of that strategy, the content of that strategy. You have to understand what goes into that, and particularly because some of these strategies are really broad things. And it has to contain mechanisms of change. So that's where intervention mapping and implementation mapping come in. This was from an article that I wasn't involved in, where Byron Powell and others, where they talk about the need to enhance methods for designing and tailoring implementation strategies. And they mention, among other things, intervention mapping is not the only way, but they mention intervention mapping. So remember I said that it can be used for designing, for dissemination, but also for designing implementation strategies. So that's what implementation mapping is. It's the use of the intervention mapping protocol for planning implementation strategies. And it's really sort of a combination of like, what can we take from implementation science and use it during this planning process to develop strategies that we're more confident are actually going to work, because we've taken the time to really think through what's happening here, and why is it happening, and what are the mechanisms of change that we can use to influence changes in those determinants, and then how do we operationalize them in a way that's consistent with the context that we're working in. So it helps answer questions like, who's going to decide to use the program and implement and ensure that it's going to continue? What do they need to do? Exactly, what do they need to do, right? When I first, I'm lucky because I got involved in implementation science like really early on. And so I got to like meet people, luminaries in the field, like Russ Glasgow and Larry Green and the other Larry Green. You know, and sometimes I'd be sitting around this table, and it was like a think tank sort of thing, and I'd say something from intervention mapping, because this is like in my brain. I'd say, you know, we really should think about who has to do what to implement this intervention. And people would be like, wow, yeah, that's a good point. They thought I was really smart, and I was just like following intervention mapping. So it helps us understand who would do it, what do they have to do, why would they do it? Seems easy, right? Seems like common sense, right? People don't do this. People do not do this. And well, not, I'm sure some people do it. In fact, intervention mapping was developed by studying what good interventionists did. So I'm sure that a lot of implementation strategy planners do something like this, right? But a lot don't. And then how and what methods and strategies influence those. So these are just the tasks of implementation mapping. I'm going to just skip through. Here, I'm just going to give you a couple examples. So this is from a project called the Peace of Mind Program, and it was an intervention that was developed for the clinical setting to decrease mammography no-shows among African American women. The clinics were losing a lot of money. People in the community were getting motivated, and they would make an appointment, but then they wouldn't show up. Right? So it was an intervention that was developed, and it worked. And it had a lot of different, it was a multi-level intervention. It had several different components, including like a counseling call that people would do the day before to address barriers and some other things. And so here's some performance objectives using implementation mapping. So the clinic decision maker will communicate with staff about the practice change, designate time for the training. The program champion will arrange for the changes in the EHR or reporting for the Peace of Mind program, arrange for patient referrals, the navigator. Well, so see how like each person in the role has a role in implementing the program, and sometimes at different levels. Articulating those performance objectives was really important. And then the determinants can come from individual theories or integrated frameworks. The methods, again, from individual theories or integrated frameworks. And the strategies are how you operationalize those methods. So there's not one list of strategies, because those can be developed depending on, as I said, on the context, et cetera. So this is just sort of an example of from that Peace of Mind program. I'm gonna try to wrap up in just a couple of minutes to make sure we have some time for questions and discussion. But I did want to tell you about this cool project that I'm involved in, and we just got this published. This is the study protocol. This is Quit Smart Utah, and it's a project to increase tobacco cessation, in particular the implementation of Ask, Advise, Connect. So Dave Wetter is the PI of this study, and they actually developed Ask, Advise, Connect, which essentially is that the primary care provider it's like the 5 A's. You guys have heard of the 5 A's, except instead of like advising, you advise, but then you connect them to the quit line. And the difference is that instead of just referring someone and say you should call the quit line, it actually connects the person's information to the quit line. The quit line proactively calls them. So I got involved when Dr. Wetter was still in Texas with Ask, Advise, Connect, not because I'm a tobacco person or researcher, but because this was the most effective intervention I had ever seen. It showed a 30-fold increase, right, in enrollment in quit line. And then also the cessation was equivalent to when people are motivated enough to call, right? That was one worry, right? And you're increasing reach tremendously, but what about effectiveness, right? So, and we kind of expected that we were going to increase reach. Effectiveness was going to be lower because these are unmotivated callers, but that didn't happen. Actually, reach was increased and effectiveness was increased. So just a phenomenal intervention. And you know, just taking it back to this inequity issue, when you look at the relative risk of smoking, it has actually increased over time, right? The difference between somebody without a high school degree, less than high school versus college increased from 1965 to 7 percentage points to 17 percentage points in 2015. So in this study, it's an multi-level intervention. One of the critical things was the partners involved, and the partners included the FQHCs, 11 systems, 33 clinics, the tobacco quit line, the Utah Department of Health, who reallocated some of their resources, the Primary Care Association also. And what I really wanted to show you was this, and I know it's complicated, but this was the conceptual framework that we actually included in the grant. It's in the paper that I mentioned. And this kind of shows you how we used the implementation science framework and also behavioral science theory to inform intervention mapping. Now, it doesn't give you details like, well, what part of intervention mapping? But in the paper, we talk about it a little bit. And so in the consolidated framework for implementation research, there are things related to the implementation climate or the intervention characteristics that are important and informed the planning. All right, so, and then this is just, it's a SMART design, sequential multiple assignment randomized trial, where we're randomizing clinics first into either receiving Ask, Advise, Connect, opt-in or opt-out. So the provider either has to opt out or they have to go and click to opt in. And then depending on whether or not a person enrolls in the quit line, they get text messages or not. And then depending on whether they enroll, they get a more intensive intervention or not. So this is I just put this up here because these kinds of adaptive designs are really useful for testing multi-level interventions, and also for you know, for saving resources, right? Because you're using the low resource intervention first. I'm almost done here. This is just a point of discussion. Is it a multi-level intervention or is it a multi-level implementation strategy, right? I get this question a lot, like, how do I know what I'm doing? And it's interesting because if you talk to public health people, they'll tell you something different than implementation science or people in healthcare services, right? Part of the answer is it depends what you're implementing, right? If you are implementing something like guidelines, right? Actually, the bottom line, to make it short because I'm out of time, is that it doesn't really matter what you call it, as long as you use a systematic process to get there, right? And we can have some more discussion about this, but I think that that the distinction oftentimes has to do with what is the innovation that you're implementing. Back to complexity, I just wanted to note that there are a number of different techniques to address this complexity. So in addition to the things that we've been talking about today, I think that there's a lot of promise in some of these other methods. And important to know that, and to keep in mind that when you introduce something new into a system, things are going to happen. And trying to understand and get a handle on some of that complexity can help you predict what might happen. So there's a lot to learn about how to develop multi-level interventions, but systematic planning can help. It's really important to think about the dynamic and complex nature of the environment and also potential interactions of intervention components at different levels. And I think that implementation science, sorry, can help bridge this gap by both better identifying and creating pragmatic knowledge that can be used to understand, and also to develop strategies to influence these multiple levels. So I put this picture up here, which was a couple months ago in Iceland. I really wanted this picture, but it was super scary for me. And so it's like been this metaphor, like something's really hard, scary, but we can do it, and success. So thank you very much for your attention. I'd be happy to take questions or discussion.
We do have a few minutes for questions. When you do need to leave, please fill out your evaluation and leave them on the desk. And if you haven't already signed in, try to.
Yes.
So I don't know. This is going to be a hard question. It's just interesting about listening to the talk. And working with vaccine. And what's really difficult about the approach designing interventions, all these theoretical based on parents providers, think is needed, and then you design interventions and they don't.
Yeah. Yeah.
It's really interesting how there's total, it feels to me it's a complete breakdown in the translation of theory into action.
Yeah.
I wonder if you have any
yeah, so what is that? All theories are wrong, but some of them are helpful. One of the things that I like about intervention mapping is that you're not using one theory. It's an eclectic approach, right? Because why? Because you're not testing that theory. That's not the purpose. We're just developing an intervention. And we know that no one theory or the constructs within one theory are going to explain all of the variants in a particular behavior, right? And so the process helps us identify all of those things that could be influencing and making sure that you're addressing those. Now, sometimes you can't address all of them because you don't have the resources or time. But if you do it right, at least you know. And if you don't know the first time, you'll know after it doesn't work, because you start exploring, well, why didn't it work? Where was the breakdown? What didn't we anticipate, right? And so you can build this logic model, and you can do it, the logic model of the problem, if you want to understand the problem first. And you can say, well, we intervened here, here, and here. It didn't work. Maybe if we put a little bit more attention over here, right? And that's assuming that the intervention strategies that you used to intervene there actually worked, right? So those worked, but it didn't translate into the behavior. And this can be very, very helpful. Like I've done this. This has happened. It also could be helpful to get more funding. So just a really quick example. So I was working on a project to develop an intervention for farm workers to decrease like heat exhaustion and other problems with heat. And so the money was for an educational program for farm workers. And we, you know, things like sun protection, et cetera, drinking water, all this stuff, and rest. But then as we were doing this needs assessment, and by the way, I was the methods person. I didn't know anything about this topic area, but we had other experts that did. And, you know, there were lots of reasons why people weren't drinking. They didn't want to have to go to the bathroom because they were paid on how much they gathered, right? There was a lot of different reasons. There was no water. Apparently, if you're small enough, the farm is small enough, you don't have to follow any of the OSHA guidelines, right? So there was huge problems in the environment that influenced why this didn't work, right? It had nothing to do with their motivation, knowledge, self-efficacy, none of that. So we were able to show that partly because we had this comprehensive model that showed all of these different elements. And we got to a point where, I mean, I just said, I'm not doing this. I am not going to do this project if we can't do something for the environment, something for the managers and stuff like that. And we actually got additional funding to do it because it's hard to argue, right? And I know that, and I know that maybe partly answers your question, but I think that the mindset of we're learning as we go, and it's, if we keep asking, well, why didn't it work? What worked? What didn't we anticipate? Then we can get there, I think. I hope. Other questions? I'd be happy to talk with anybody at another time. I know I'm pretty booked today, but feel free to contact me with email or phone, and be happy to talk more with you. Thank you so much for your attention. Appreciate it.